All right, doctor. So I hope you're ready.
Hello.
Just a
Hello.
moment. Just a moment. Sorry. There you go. That's your patient. You may start.
Hello. My name is Dr. Ogbechi. I'm one of the doctors in the medical admissions unit today. Are you Mrs. John Snow White, 35-year-old?
Yes, doctor. I'm John Snow White, 35 years.
Right. I'm here to talk to you about the complaints you've been having. Can you tell me more about the headache you complained of?
Yes, doctor. Now I've been having this headache. It comes and goes, and at times they can be very severe. And I have these migraines, but it's quite unusual. Like in the sense, like previously the headaches they were mostly on the right side, but they're all over my head now, and they come anytime. And when they appear, I feel very anxious. I don't know why.
Oh, I'm sorry to hear that. You've been having this for 4 weeks. And
Yes.
you mentioned that you've had migraines in the past.
Yes, doctor.
Was it diagnosed?
Yes, it's diagnosed.
Right. Okay. So is there anything that makes this headache better?
No, it's just, it's not always that it gets better on its own.
Right. And on a scale of 1 to 10, can you tell me how bad is it, with the 10 being the worst headache?
I would give it a score of 7 out of 10.
Okay. Do you have any headache at this time?
No.
Okay. And you say you feel it around the head, all around the head?
All around my head.
Okay. I'm sorry to hear that. Any raised temperature?
No, I didn't notice any raised temperature.
Okay. Does the headache, can you describe does it feel like a tight band around your head?
It's not exactly a tight band. It's like, how would I going to explain it? It's like something that develops inside my head. It's all around my head. And when it appears, I don't feel that good, doctor. I feel like, I'm very anxious.
Sorry to hear that. Any stiffness of your neck?
No, I don't have any neck stiffness.
Any problems with your vision?
No, I can see fine.
Right. Have you had any problems with your weight?
With my weight?
Yes.
No, my weight has been staying.
Okay. What's your BMI?
It's 24.
Okay. Any stressors in your life?
Of course, I have stresses. I'm a school teacher and I teach in the kindergarten, so I have lots of students, and they talk a lot, so I need to make them quiet. And with the headache, sometimes it gets really annoying, I would say.
Okay, so I'm sorry to hear that. Have you noticed any rash? I can see you have some on your face.
Oh, doctor, don't mention it. I have these rashes for a long time, and previously I got some treatments, some lasers to remove them. Okay, but they keep on appearing.
Okay, sorry to hear that. It must be causing you a lot of distress. Can you tell me what treatments you've had in the past?
I just had some laser therapy for this.
Laser therapy, okay. Yes. Have you taken any medication by mouth?
No.
Okay. A few details about your medical history. Have you been diagnosed with any medical condition in the past?
No.
Okay. Any history of pregnancy?
Yes, doctor. I have a kid.
Okay. Are you on any birth pills, contraceptive pills?
No.
Okay. When was your last period?
2 weeks back.
Okay. Are you on any over-the-counter medication?
I take paracetamol, doctor, for the headache.
Okay. And any drug allergies?
No, I don't have any medication allergies. No.
Okay. So I would like to examine you while I speak with you. So sure. I've noted the rash. Okay. I've noted the rash. I would like to take your blood pressure.
All right. So the blood pressure on the right arm is 150/90. On the left arm is also 150/90.
Right. Okay. So I would like to look at the back of your eyes, the fundus.
You wish to check the fundus, okay? So
yes.
Any comment that you wish to give to her before you?
Okay. So I'm going to shine a bright light into your eye. So look at the spot behind me and just stare straight at it.
Okay. So this is what you notice when you look through your fundoscope.
Right. Okay.
tell me when you're done.
Yes, I'm done. I'm done
All right.
with the fundus. Okay. So do you smoke?
I do, yes.
Okay. How much of cigarettes do you smoke per day?
5 to 6 sticks.
All right. And do you take alcohol?
I do.
How many
10
how much
units in a week.
alcohol do you drink?
10 units in a
Okay.
week.
And I ask this to all my patients, so please don't be offended. Do you take recreational drugs?
No.
Right. Okay. So Mrs. John Snow White, I want to ask you a few other general questions, if you don't mind. Is this headache worse at the end of the day?
No, doctor. It has no relation with any timing of the day. It can come any time.
Have you noticed any lumps and bumps?
Lumps and bumps. I mean, the rash
Anywhere?
that I have over my face, they're in other parts as well. It's a bit bumpy. I can feel it, doctor. You can also feel it for yourself. Okay,
so I can see them on your hands. Do you have them on any other part of your body apart from your face and hands?
Yes, doctor. They're all over my body.
Okay. Do you have any problems with your Do you have any problems with your waterworks?
With my waterworks?
Yes.
What kind of problem, doctor?
Have you noticed any frothy waters? Any
no
frothy waters?
No frothy waters.
Okay. Any problem with your bowel works?
No.
Any problems with your temperature? Are you sensitive to certain temperatures?
I'm all right with any temperature, doctor. I can quite adjust to it.
Okay. And any muscle cramps?
No muscle cramps.
Okay. Any pains in any joints?
Sometimes I have joint pains, doctor. I mean, I walk a lot. I don't use any buses or taxis. I go to the school walking. I love walking. So sometimes my joints are sore after I come back walking.
Okay. Sorry to hear that. Does it get better with pain medications?
No, it just gets better with rest. One day it gets better.
Okay. Have you noticed that your rings don't fit you any longer?
No, I'm wearing my ring. You can still see it. I have it on me.
So, Mrs. John Snow White, can you tell me what your concerns are?
Doctor, why I'm feeling so anxious? Like this headache, it's killing me. Moreover, I don't know. I panic a lot these days. And I'm really worried. My husband says that I look always worried. Do you think I have developed any mood disorder?
Well, a headache and a mood, your headache is not likely to be explained by a mood disorder. It's more likely to be explained by a physical problems with your body. Your blood pressure, I noticed that your blood pressure is high, even though you don't have any medical condition. So the headache could be related to the blood pressure. And I would like to investigate you in that regard. Do you have any other concerns?
No, your time's up. Tell us your positive findings and diagnosis.
Positive findings are of a facial rash, elevated blood pressure. On fundoscopy, the fundus looked normal. The fundus appeared normal.
Okay.
Yes. So my diagnosis is headache related to hypertension.
Sorry, I couldn't catch you. Could you please repeat?
My diagnosis is the headache related to hypertension.
Okay. Headache related to hypertension. And any other cause? So what's your differential for the rash she has over her face?
The rash on the face looked like acne.
Okay.
Yes, and a differential I would have thought was related to medication use, but she denied any use of medication.
Okay, all right. So how are you going to investigate and manage this headache?
Okay, I would like to investigate this headache by looking for a secondary cause of headache. Even though I wasn't able to identify one on history, I would like to do the urea and creatinine to look at the kidney functions. I would also like to do an ECG to check the cardiac rhythm. I would also like to do a thyroid function test and check the urine for protein.
Excellent. All right. Anything else you'd like to do?
Well, I would also like to check them for urine metanephrine, just to rule out a pheochromocytoma.
Okay. Right. Your time's up now. You move on to your next patient. All right.
Hello, my name is Dr. Obeche. I'm one of the doctors in medical assessment unit. Are you Mrs. Jessie Thomas, 35-year-old?
Yes, Doctor. I'm Jessie Thomas, 35 years.
Okay, so I'm here to talk to you about the complaints you've been having. Can you tell me?
Yes,
tell me
Doctor.
what problems
I've been feeling tired, Doctor. I've been feeling so tired that these days I don't feel like walking anymore. I love to be seated, and whenever I rise up, I feel like a bit lightheaded. Okay, and I've also noticed that I've lost a bit of weight. Okay, and I don't know why life doesn't feel that pleasant anymore.
Well, I'm sorry to hear that. When have you been having these complaints? Since when?
This has been going on for the last 2 months.
Okay, I'm sorry to hear that. This tiredness, is it worse at any time of the day?
No, it's all the time I'm tired.
Right. Have you noticed any shakiness of your body?
Shakiness? No, I don't have
shakiness of your hands?
No.
Okay, any neck swelling or lumps and bumps anywhere?
I don't have any neck swelling, but you can see like it's actually like this. My leg has always been like this, Doctor. They call me I have a double chin. It's beauty.
Okay, I can notice a swelling in the neck. You said your neck has always been like this?
Yes.
Okay, right. Any rashes anywhere?
Oh, Doctor, you can see over my face. I think I've developed this rash, and this is developing gradually. The first time I noticed that it was a small area, I had this loss of color, and over the last 6 months, I would say, it has developed this. And not only here, over my face, in many other parts of my body, I have lost my color.
Okay, do you see this rash over areas where you have a scratch or any injury?
Yes, Doctor. Very much, like especially the areas where I have these frictions, where I wear.
Okay. Have you noticed any
those areas?
Right. Okay. Have you noticed any hair loss? Any loss of any of your hairs?
Oh yes, Doctor. I have an increased hair fall lately.
Okay. Sorry about that. Any difficulty with combing your hair or getting up from a standing position?
I have difficulty getting up from standing position. I feel lightheaded, but I can comb my hair.
Okay. Okay. So any soreness or stiffness of your muscles?
No, my muscles are okay.
Okay. Any joint pains?
Joint pains? No, I don't have any joint pains.
And any raised temperature?
No.
Okay. So your past medical history, is there anything significant in your history? Have you been diagnosed with any medical condition?
I had to go and visit my woman doctor a number of times. That's because I wasn't having my periods, and they stopped 2 years back.
Okay. Okay. So your period stopped 2 years back. Have you been pregnant before?
Yes, I was pregnant before.
Okay. Any pregnancy losses?
No.
Are you on any pills to prevent pregnancy?
No, doctor. I don't have my periods for 2 years. Why would I take pills?
Okay. Are you on any regular medication?
No, doctor.
Okay. So I would like to examine you while I talk to you.
Sure.
So I observe you. I can observe the hypopigmented patches. So I like to check your pulses.
Okay.
For the two pulses for synchronicity.
Also
your blood pressure,
sitting and
standing blood pressure.
All right. So the sitting blood pressure is 100/60, and when the patient stands up, it gets to at times 80/50.
Okay, all right. So do you smoke? I mean,
No, doctor, I don't
I
smoke.
look at your eyes,
don't
I look
smoke.
for pallor.
She's pale.
All right. Okay. So, okay. Do you take alcohol? Have you ever taken alcohol?
Yes, I drink alcohol.
You take alcohol?
I do.
So, okay. Is it okay? How much of alcohol do you drink?
I drink around 10 units
I'll
in a
tell her
week.
to. Okay, 10. Okay. So I ask this to all my patients, so please don't be offended. Do you use any recreational drugs?
No.
Okay. What do you do for a living?
Doctor, I'm a driver.
Okay. So how has this condition affected your day-to-day life? Are you able to cope with driving?
I'm not able to cope, doctor. It's like I said, I feel so tired. I don't know why I'm feeling so tired lately. I don't have the energy to go to work.
I will advise that you stop driving. Okay, I'm sorry to hear that. I will advise that you stop driving, and then we'll get to the bottom of what your complaints are. Okay, so what are your concerns? I'm still examining you. I'm palpating. Okay. Yes, I'm palpating the abdomen. Yes, I'm palpating the abdomen. I'm looking for any tenderness. I'm looking for the liver area for any hepatomegaly, and also I would want to listen to
in the abdomen. Okay, in the abdomen, you find no organomegaly. Okay, and the vowel sounds are quite audible.
Okay. So what are your concerns, Mrs. Thomas?
Doctor, I'm feeling so tired. Can't I get back to my normal life that I had before? I enjoy driving. You said I cannot drive. So how long will that be?
Oh. So, that will be till after we've started you on treatment. From speaking with you and examining you, it looks like you have a condition with your glands, the glands in your body. Don't bother about the term, but we call it autoimmune polyglandular syndrome. So once we place you on some medications, you'll feel better. Do you have any similar condition in your family?
My family? No, doctor.
Yes.
In my family, everyone has energy. I mean, they don't feel tired like me.
Okay. Okay. All right. So do you have any other concerns?
Doctor, can it be treated? Can I get back to my normal life?
Yes, it can be treated. I would refer you to the gland doctors who would start you on some medications to make you feel better, because of different glands in your body are affected by these complaints. So once we start your medication, you will feel better and you'll be able to start your normal life gradually. Is that okay?
Okay. So doctor, give me the medications now. I will go home.
No. So because of what the complaints you've been having, especially related to your blood pressure, we need to keep you in the hospital, to admit you in the hospital to start the tests and the treatments.
All right, your time's up. All right, doctor. So tell us your positive findings and diagnosis.
Okay. The positive findings is on examination. This lady had vitiligo, obvious on hypopigmented patches on the face. She was pale, and she had standing blood pressure 100/60 and a line blood pressure 160 and a standing blood pressure 80/50. Abdominal examination was normal. My diagnosis is autoimmune polyglandular syndrome, and with involvement of with vitiligo, possibly pernicious anemia, and possibly an Addison's because of the orthostatic hypertension. And I would like to investigate her in this regard.
Okay, so there are two types of autoimmune polyarthritis syndrome. So which one your patient has?
My patient most likely has the type 2 autoimmune polyglandular syndrome.
And what points in favor that you have found?
Okay, what points in favor is the likely hypoadrenalism, the vitiligo, the vitiligo, and well, I could appreciate a swelling in the neck, which she she attributed to her natural self. I don't know if it's just because of a picture, but it looked like a neck mask to me.
All right. So tell me your investigation plan.
I would like to investigate her by doing a HbA1c to look for diabetes, also urea and creatinine to look for high the sodium and potassium, which would point towards adrenal failure. I would look at for thyroid function tests. I would also like to do a complete blood count to look for anemia, and the red cell panel to look for macrocytic anemia as well.
Okay, so how are you going to manage this patient?
Because of the adrenal involvement, I would like to commence on steroid replacement with hydrocortisone first, and depending on the other investigation results, to advise further management.
Okay, thank you. We will move on to your next station. All right.
Thank you.
Okay. So, why you consider the patient to have autoimmune polyendocrine syndrome when you have found just patient having features of Addison's? Did you find any features of any thyroid disorder, or whether the patient had any features of diabetes? Did you explore them?
Well, just because of the vitiligo, actually, the vitiligo
Okay.
and the Addison. Because sometimes in autoimmune polyglandular, they don't have all the features complete. So once you have more than one feature, is suggestive of a polyglandular syndrome.
All right. Okay. What things you check in particular in a patient with Addison's, and did you check for them on this patient?
Okay,
like, let's say you are trying to discover if someone has Addison's, right? So what particular things you would look forward to? What would you examine? What things you missed? What do you think? What you could have done better?
Okay, I think I should have checked for proximal myopathy.
And I think you did that.
No, I
what
did
else? You say if I have difficulty combing my hair. I was thinking that you were checking for proximal myopathy.
No, I thought you meant on examination.
Yes, on examination. What else you do? Would you check inside the mouth for anything?
Okay, yes, for buccal hyperpigmentation.
Yes. Okay. All right. Anyways, so this lady has presented with fatigue, and the fatigue has been going on for months. Okay. And like, we always try, like we ourselves, we do difficult cases at times, but this is also a very common case in the exam that you might come up with. Okay. And Addison's, autoimmune polyendocrine syndrome are very common. Okay. In every diet they're tested, and you should have a very organized approach for them. Okay. And you can also imagine them, like if you don't see such a patient, you can also imagine them always. Okay. So the biggest wall is the wall of imagination. Everything is possible there. You can achieve anything, you can do anything, and no one sees you. So it's a wall of imagination, okay, that Allah has provided you, the mind. Okay. So you can do many things in the mind. You can like play there, you can practice there, you can do anything. Okay. So just imagine that if the patient is in front of you and she has this appearance, first of all, she has this characteristic rash. Okay. And you see they're symmetrical. And not only it has involved her face, it has also involved parts of her hair. It has also involved parts of her eyebrows. Okay. And I don't literally see her eyebrows. Maybe lateral you see there is some eyebrows missing. So she could be having some features of hypothyroidism alone. Okay. So we are not sure. So there were some good questions that came forward from you, that you tried to describe this rash, but you could have said that this rash, for how long you have it, and you asked about the Koebner phenomena, that whether it increases after trauma. Okay, so that's a very good analysis. You could have asked if you have noticed it has anything to do with the sunlight. If sunlight makes it hoarse. Okay, all right. So that could have been very important. And you could have asked to see the hands. Okay, like you asked her if she's wearing any ring. So this is her hand. You can see, notice that there are also some hypopigmented areas. Okay, and you could have asked to check other sites. You will find this in the legs. Now, anytime you find the hypopigmented area in your exam, you should touch it. Why? You should check if there is any loss of sensation. To rule out any fungal infection, to rule out leprosy, just to exclude the differentials of hyperpigmentation. Okay, you should also look for if there is any scales. And asking about sunlight whenever you have a rash, asking about photosensitivity is first. That means you must do it. Okay, now forget the rash. You got a rash and the rash seems like it's vitiligo. In the exam, if you get any rashes like vitiligo, any rashes like something that bears autoimmune, okay, with it, the tag, okay, so these are brands, okay, they don't come together. These are brands. Like if you buy vitiligo, you have to buy alongside few other things. Okay, so we call it the dat piece. Okay, beside this we say the VM. So the dat piece are diabetes, Addison's, thyroid disorders, autoimmune, pernicious anemia, vitiligo, myasthenia. Okay, and plus you can add on to it the autoimmune. So I mean, this is like you buy one thing, these are the other things you find in bonus. Okay, you should always explore for them. So if they give you a patient with this characteristic rash, they haven't given this to you just for the diagnosis. Anyone can diagnose them, but not all can explore what other things they are carrying inside them. So you have to explore whether the patient has these other features, the DAT PVM. So you found the vitiligo fine, you explored it. Then you can ask this patient, her main complaint was tiredness. So how do you correlate this vitiligo plus fatigue? So what would be your differential for it? So you can bring some, like Addison's can give you this fatigue, thyroid problems can give you this fatigue. Pernicious anemia can also add on to this fatigue. So you can quickly ask, do you look a bit paler than before? Yes, I am. I look pale. Bingo. Your patient might be having pernicious anemia. Okay? Because you found vitiligo patient is anemic or patient looks pale. You should be considering pernicious anemia. Okay? So ask few more questions. Do you have any preference to hot and cold for the thyroid? No. Okay? So fine. There is any thyroid disorder. Do you feel dizzy when you're rising from sitting position? Yes, I do. Then you're dealing with Addison's, and patients with Addison's can also have, or they are fatigued. Okay? So you also notice from the outside, the blood pressure was on the lower side, and she volunteered this info that she feels a bit lightheaded when she rises up from sitting position. So you should be considering Addison's, okay, alongside. So what you need to do here, you need to do a review for each of them separately. Like if you are doing for the Addison's, okay, you can ask this patient that, do you feel dizzy when you rise up from sitting position? Have you noticed any increased pigmentation anywhere? Or you have to watch it for yourself. Okay, do you feel dizzy, lightheaded anytime you had any fainting attack? Okay, anytime you fainted? Okay, any complications of this Addison? Anytime she collapsed? Okay, how is her appetite? Okay, how is her appetite? Whether she had any weight changes? Okay, so usually patients with Addison, they have weight loss, they're fatigued, okay, and they lose their appetite as well. Okay, so you can ask about such thing. All right, then you can explore for the thyroid, like do you have any problem with the preference to hot and cold? Okay, do you have any weight gain? So asking about weight changes is very important. Okay, here, so you must ask about the weight, any weight changes. In the station 5, asking about weight changes, the general queries are very, very important. Okay, pain can be seen in Addison, also hypoglycemic attacks, loose motions. Very important to ask motions, loose motion. Very important to rule out the celiac. Yes, rightly said. Okay, so you have to screen for what you mean one by one. So for Addison's, you do something, and so keep in mind that you have to check for buccal pigmentation. You have to check for the pigmentation at other sites. Okay, you have to ask for postural hypertension. For thyroid, there is a neck lump noticeable to you. Now, let's say you find something suspicious there. So what should you do? You should offer her a glass of water, ask her to take a sip and notice if it moves up and down with the swelling. Now the patient can have a double chin. Okay, sometimes in patients who have Cushing syndrome, some have this double chin, there. So just to rule out your suspicion, you can just offer the patient a sip of water, ask the patient to swallow, and you will notice if anything moves up and down. Then you have a goiter, you have a thyroid mass. Then you have to figure out whether this is hyperthyroid or hypothyroid from the history and your examination. Done. You could have done it. Moreover, you could just check the eyes for if the patient has this pernicious anemia, should be pale. Look at the mouth. Okay, so you didn't examine the mouth, which was necessary for any pigmentation, also for any vitamin deficiencies that patients can develop. Okay, they can have mouth sores, right? You can ask the patient if the patient had any tingling numbness anywhere. Okay, this tingling numbness could be due to diabetes if the patient has, or this could be also due to the B12 deficiency. You could ask the patient, do you feel thirsty? Do you feel thirsty? Do you have any increased water work? So these are the general queries: wet changes, any lumps and bumps anywhere for thyroid lumps, okay? And any raised temperature, fine. There wasn't a raised temperature. Any changes with the water work, bowel work, with the appetite and diet, very important. Okay, so the general queries could have been explored a bit more. Okay, now furthermore, you ask some good questions. Any hair loss? They can have hair loss. Okay, there are some other autoimmune conditions, alopecia areata can develop. They can have hair loss. They can have premature ovarian failure, another autoimmune condition. They can have joint pains. Okay, so one autoimmune calls back to all other autoimmune. Okay, so you have to do a very thorough screening. Okay, and one good thing she also did. Okay, whenever we criticize, we should also highlight on the good things that the candidate do. So she asked about this weakness at any particular time of the day. So first of all, when it was fatigue, you should explore the symptom, that this tiredness, for how long you have it, like the OD para at the onset. Is this something very acute, or this has developed gradually? The duration, for how long? Okay, let's say for the last 3 to 4 months. Okay, and is it always there, or it comes and goes? Like if it's myasthenia gravis or Lambert-Eaton myasthenic syndrome, it's going to come and go. It's not going to be always there. Like at the end of the day, she's going to be more fatigued. So we ask about whether it's intermittent or whether it's something progressive that's always there. If something is progressive, then it could be due to this pernicious anemia. The patient is pain. The patient always feels tired. Okay, it could be due to Addison's, always feeling low. Okay, especially in the early morning. Okay, and any associations, anything that makes it worse, this tiredness. Okay, anything that makes it better, the relieving factors, and all the associations that PVM. Okay, asking about autoimmune ovarian failure, asking about hair falls. You do the full autoimmune screen quickly with some nearby questions. Then quickly go to your examination. Now, when you go to examine this patient, what should you do? Patient came to you with tiredness. Patient says she looks faint. Start with the eyes. You can just look here, look for anemia, look for jaundice. Why jaundice? Because sometimes patients are anemic. They can have autoimmune hemolytic anemia. They can be icteric. You don't want to miss that. Okay. Then you can ask for the observation chart, ask to measure the lying and standing blood pressure, watch for any postural hypertension. You find postural hypertension, ask her to open her mouth, look for the buccal pigmentation. Okay, look for the pigmentation in the gums. Okay, so this is what you could have done there. Also look for any mouth sores. Okay, that confirms patient has Addison's. So you find Addison's, you need, among the that you found the A, look for, ask the patient if there is any increased water work. Okay, and also ask the patient for any preference to hot and cold. Look for any thyroid lump. You could have examined for that as well. Okay, and you could have also examined the rash. Just feel over it. Can you feel, I mean, can you, do you have feelings here? Can you feel it? Can you sense it? Yes, it's not like, some hyperpigmented lesions. They can be due to leprosy, they can be due to fungal infection. Okay, there are various differential for this hyperpigmented lesion. Now, patient didn't come to you with the rash, so we do not need to go into details about the rash. If the patient would have come to us with the rash, we'll start examination with the rash. So the station 5 is very tricky. You have to understand what you have to start with. Don't get misled by the signs. A patient can carry lots of signs. Okay, like this patient, she has many signs, but you have to focus on one, and that is her complaint. So her complaint is tiredness. You move to the cause for the pallor first. You move to the observation for the Addison's, confirm it. We are not worried about the rash. If you have extra time, you can just check the rash. But if the patient came to you with this rash was a problem, we'll first notice the rash, look every site where she has this rash. Okay, and then we'll explore things more related to the rash. But rash is not our problem. Okay, our problem is the fatigue. So we're going to assess for the fatigue. Now you check the abdomen. Okay, now, okay, you can check the abdomen, but what certain things you can look for? So here, if you would have asked for the bowel work, if the patient said, I have loose motion, okay, you must ask, what's the character of your loose motion? Now you asked me the bowel problem, perhaps I said no problem, but sometimes they have loose motion, you have to consider celiac then, okay? You have to consider IBD, that's why you have to check for any tenderness in the tummy, okay? So you have to rule them out. That's why it's very important to check them out. They're all related. It's a spiral, okay? But you do not need to do everything there. You just have to be focused, because this is station 5. The another synonym for it is focused, okay? Now, trust me, many good candidates, like in the past also from the feedbacks, they have done really well in all the clinical station, but when it comes to station 5, they lose mark. They don't get mark in examination. They do poor in the judgment, okay? But all of them can manage the communication. They take a very good history. They can take history for 5 minutes. So the examiners, they give them full marks in the communication, but they fail in the examination and science. Why they're failing in science? Because they're not looking for the science. And they don't know which signs to pick up and which signs to mention to the examiner. Okay, so let it not be like that. Okay, try to be focused. You are smart. Okay, so we're going to be focused and we know what to look for. So a patient comes to it vitiligo and fatigue. You explore the causes of the fatigue. Watch for the cause of the fatigue. So look for if she's anemic. Look for signs in the hands. Like establish pallor. Look inside the mouth. Confirm your diagnosis of Addison's by looking for the pigmentation. Okay. If it was just Addison's, then we could have sought the causes for the Addison's. But here, it's something very clear that this is an autoimmune etiology. Most likely, it is relevant with the vitiligo. But there could be others. So ask for any past history. Ask for any past history, the PDF. Any past history, any medication she's on, any medication if she was on, if she stopped, and if she has any family history. Okay, so the polyendocrine syndrome, or if you are considering like some in other cases, men, let's say family history bears a lot of significance. You should always ask about the family history, and for any female, you should be always asking about the periods. And she did that. Okay, so overall, your communication was satisfactory, and you asked the patient not to drive. Addison's is not a condition for which you can ask the patient not to drive. Okay, but if she has any problem with the vision, if she has fainting attacks which cannot be explained yet, in such case, we could have asked her to stop driving momentarily. So you should ask any patient with pallor that do you have any racing pacing of your heart? Because if you have anemia, there can be shortness of breath, there can be palpitation. Okay, so you should ask those questions as well, like any complication of the anemia if the patient has anemia. Okay, if you think the patient has anemia, the likely cause will be pernicious, so you should include them in your investigation. So it's very simple. You just discover the patient has the features of Addison's, you find the patient is anemic, and you find the patient has this vitiligo. And there aren't any other signs that you're going to pick up from this case. If you're suspicious the patient could be having a neck lump, amenorrhea due to hypothyroidism or premature, not hypothyroidism. Hypothyroidism gives you menorrhagia, whereas hyperthyroidism gives you amenorrhea or irregular periods at times. Okay, whenever your patient is amenorrheic, it's very important to ask about the weight. What if she's having polycystic ovary? You don't know. Okay, so it's always important to offer and ask about the weight, any weight changes in the station 5. If you don't ask it, you're doing a big mistake. You're going to fall behind. Okay, moreover, you should also ask and suggest a pregnancy test, because patient lies, like Dr. House says. Okay, patient's lives. Okay, so I was once penalized. I lost 3 marks for this pregnancy test. I got 25 out of 28 just because I didn't mention the pregnancy test, and the case was acute pyelonephritis. Okay, I never forgot to mention about the pregnancy test to my candidates and to my peers back then. I always emphasize on the pregnancy test. Okay, and it helped me later on to score 20 out of 28. Okay, so don't miss the pregnancy test, don't miss the history of pregnancy. Okay, that's very, very important. All right, now we're done with this case. Okay, so once you're done with the examination, now there comes a part, the last 2 minutes for the concerns. And here, if you are dealing with a patient with Addison's again and again, if you don't mention steroids, the examiners will forget to give you any marks. You should mention her about the steroids. It's not important to admit her at this moment. She's not in Addison in crisis. Is she? She's having abdominal pain. Did you ask her, do you have any abdominal pain? If she's in crisis, that's a different thing. Okay. Patients who have this Addison in crisis, okay, what are going to be their complaint? They might have a pre-existing condition. They might have lots of stresses. Okay. They might be having hypotension. They might be in shock as well. This usually happens if you are withdrawing steroids. Okay. But not primarily. In such case, we need to admit the patient. They needs IV hydrocortisone. But here, we don't need to admit the patient. Patient is not in crisis. There's nothing very serious to admit this patient. What we can do, rather, we can refer her to the gland doctors and we can tell her that you have a condition, okay, that seems like one of your glands, which is above the kidney, okay, is not secreting enough proteins we call hormones. And this is very essential for life. We call it the cortisol, okay. And the condition you have is Addison's. Don't be worried about the term, okay. Beside this, the skin rash you have can coexist with this, okay. We call it the vitiligo, okay. And moreover, we feel like you are looking a bit pale, and at times there are some other conditions where the your defense system, okay, they get disorganized, okay, and can attack and impair the absorption of certain vitamins and minerals in your gut, okay. So you could be having also a anemia we call pernicious anemia, okay. So these are the possibilities. So the plan of management would be now to refer you to the gland doctor, and we have to replace this protein called hormone, the steroids. These are essential for your life. So you must mention about the steroids, and we are going to involve our specialist nurses. They're going to teach you how to carry these steroids or take these steroids, okay. So there will be a part of discussion about the steroid, but you don't need to do everything in the station for just mention about the steroids. With the examiner, you should say, this patient on inspection has this hypopigmented rash, okay. Don't say the patient has vitiligo. You are not skin biopsy, okay. You haven't done any blood test yet. Say the patient has this whitish discoloration symmetrically over the face, okay. Most likely, this could be vitiligo. Likely, this could be vitiligo. Don't say the patient has vitiligo over the face. Okay. So first, describe it, then mention the diagnosis. Moreover, I noticed the patient has a postural drop while standing from lying position. Okay. And patient also has this buccal pigmentation suggestive of Addison's. Moreover, I found the patient is looking a bit pale. So my differential for this patient could be having, okay, Addison's disease. The fatigue could be due to Addison's, okay. And I will also like to rule out other autoimmune condition for this patient, rule out hypothyroidism, any thyroid disorder, also rule out any type 1 diabetes, okay. And one of my differential will be also autoimmune polyendocrine syndrome, though there wasn't any family history. So you should consider Addison's first, okay, alongside vitiligo, pernicious anemia. Pernicious anemia could be also one of the reasons why she could be pale and she could be having this fatigue. So your investigation should contain the short synaptic test for Addison's, okay, serum electrolytes for Addison's, intrinsic factor antibodies, beta cell antibodies for pernicious anemia. For vitiligo, you can do a skin biopsy, involve the dermatologist. So the management should be a multi-skill team. It should be very important to educate and counsel the patient. Education and counseling about steroid replacement, carrying extra doses of steroid injections. If the patient is ever unable to take the steroids by mouth, she should be taking them by injections. Very important, ensuring she carries the steroid bracelets, okay? And doing replacement, like beside replacing the steroid, we should also replace the vitamins if she has pernicious anemia. Okay, so we should do test and we'll do the replacement. So a multidisciplinary team involving the endocrinologist. When you talk with the patient, you mention about gland doctor. When you talk with the examiner, you mention endocrinologist. It's a doctor to doctor. Okay, so the examiner should be, when you talk to the examiner, mention the medical terms. When you talk with the patient, describing her concerns, answering her concerns, use layman terms. Okay, so when we talk with the examiner, we say we need to form a multidisciplinary team. At first, educate the patient, counsel her about her condition, ensure that she has the steroid replaced and carries those extra injections of the steroid, and she's taught how to take them at the appropriate time. Beside this, we're going to involve an endocrinologist to treat her additions to the steroid replacement. Okay, we are going to treat her for the pernicious anemia if that's the cause for anemia. Okay, we're going to involve a dermatologist for the skin condition. Okay, like they can give her anything like camouflage creams, avoid sunlight. All those advices can be given by the dermatologist. And we are not bothered about it because she didn't come to us with this rash. We are here to manage her fatigue. Okay, so we have to correct the B12. And at the same time, always we say, look for complications. So if your patient is suspected to have pernicious anemia, you could ask about tingling numbness. And if the patient says, yes, I have tingling numbness, you should offer to check that, but you don't have time. Just mention to the examiner. I will also like to check or examine the patient for any peripheral neuropathy. And in the examination, or sorry, in the investigation, mention nerve conduction studies, B12 level. Okay, so you cannot do everything. It's quite impossible for anyone, but you can always suggest and remind the examiner that that was in your mind. That was what you imagined from the outside, that what you wish to do, right? Are you following? Am I too quick or am I too slow for you? Dr. Fung?
I'm following.
Okay. So
we are used to.
Okay, now what we're going to do, we're going to take understand from Dr. Fung because I have been communicating to her. So let's see, Dr. Fung, could you please repeat what you're going to do with the patient with Addison's? I was not happy with your examination sequence. So I need you to, just tell us what you're going to do if you had this patient and you'd examine the patient in 2 minutes. What things you think were feasible and you could possibly do in such setting?
I'll check the hands. Then depending on what the patient complained about. If the patient complained of pallor, I'll check pallor first. But I'll check the hands. Then I'll check the blood pressure, lying and standing. Then yes, then I check the eyes for pallor. Then I check the mouth for buccal hyperpigmentation.
Good.
Yes. Then I look for other areas. What other areas of the body.
Areas? Yes. What other areas?
I'll check the legs, the
pressure sites. Okay, sometimes. Yes. Okay, you can also check the, if the patient has any acanthosis nigricans. Many patient has it alongside any darkening in the creases. Okay, pressure sites, elbows.
Yes.
Okay.
Okay.
All right.
Okay.
And what else? For exam setting, if you check the buccal pigmentation, you find it, you move on to next examination.
I move on to what?
You move on to like the patient. You do further examination. Look for the complications. What could be the complication of Addison's?
Apart from the Addisonian crisis.
Yes, that's one. Okay, like if the patient, let's say, you already explored it, any fainting attacks, any history of collapse, those kind of thing. Let's say for the pallor, any palpitation, check the pulse. If the patient has any palpitation, ask the patient. Shortness of breath, okay? Those things should also come in the history. All right, any tingling numbness for pernicious anemia. Always assess the red flags. Once you have your diagnosis, you should ask few questions to rule out that there isn't any complication that the patient is suffering, right?
Yes.
Okay. Now, it seems like a lot to do, but it's not actually a lot to do. In real patient setting, if you have the patient in front of you, okay, at times you might get lost that what to do. There's so many signs. Just stay calm, concentrate. Always remember the complaint. Complaint was fatigue. You focus on the fatigue, okay? And the fatigue for the pallor, you check. Addison's, you confirmed, okay? If there was any muscle weakness, you can also check for proximal myopathy along, okay? If you feel she could be having thyroid lump, if you feel like you can offer, okay? But be very careful. What you don't find, don't make up any signs, okay? Like many, if the patient has a swelling like this, would say, possibly the patient has a thyroid lump. This possibly will kill you. There is no possibly in signs. Either it's present or not. It's present or not. We cannot make any signs. Should you go for ankle jerk with this? If you're suspecting patient has hypothyroidism, first you ensure this, you ask history, okay? And look for any signs, like if she doesn't have proximal myopathy, if she doesn't have other features of hypothyroidism, no weight gain, no tiredness, no change in the voice, okay? No loss of the lateral eyebrows, no puffy face, no need to go for the ankle jerk then, okay? Ankle jerk or jerks we do in hyperthyroidism, also in hypothyroidism. For thyroid disorders, if it was thyrotoxicosis, we'll do the jerks as well after checking the other peripheral signs of hypothyroidism. If the patient has hypothyroidism, we'll go for also the ankle jerk. That's something they would expect. Also checking cerebellar signs. If you're taking the exam in UK, they would expect you to check the cerebellar signs, okay? All right, what is PNM and DAT-PVB? Diabetes, Addison's, thyroid disorders, pernicious anemia, vitiligo, myasthenia, and you can add more to it. No, just in hypo it's delayed, not hyper. In hyper, you're going to get exaggerated charts. All right, let's get done with this. So this is how you do this case. So overall, I think the examination could have been better, and you could also check the palmar creases here. They would be black, like we kept a hand for you, though it's not of good resolution. Sorry for that, but I think you didn't check it. I couldn't show you that. I forgot that there was a picture like this there at the bottom. I just showed you this. So if you would have looked over the palmar creases, they can also be very dark at times. Okay. So for the treatment part, multilatin, you must mention about the steroid, bracelets. Okay. Vitamin B12 replacement. All right. And the patient should be under follow-up. And in your investigation, you can include the HbA1c, random blood sugar. Okay. They should be there to rule out type 1 diabetes. And also you should rule out in thyroid disorder, you can at least do the TSH. And the examiners are going to be happy and they're going to give you 20 or 28. Okay. All right. Are you happy, Dr. Fang?
Yes, I am.
All right. If you're happy, then I'm happy. Okay. So let's move to the other case. All right. Now, this was very tricky, and you thought the patient has acne. Okay, that's one differential. Okay, what are the differential for this kind of rash? Let's look at close. So why didn't you explore the rash? Like if you look at her, okay, if you expose her, this patient, all right, you're going to get a rash like this. Now describe what you see here, Dr. Fang.
Okay, this is hyperpigmented nodules.
Okay, so
yes,
she says hyperpigmented nodules. So I give you number 1, 2, 3, 4. So pick up 2 numbers,
okay,
which are nodules, and pick up 2 numbers which are spots.
Okay, so up number 1 is the spots.
Okay,
like
and
the cafe au lait.
It is the cafe au lait spot. It is the cafe au lait spot, but you can call it, you know, there is a hyperpigmented patch. Okay, likely cafe au lait spots. Okay, fine. Okay, and what is this? Number 2 and 1. Sorry, 2 and 3.
Okay, so those nodules, those are the neurofibromas.
These are neurofibromas. Very right. All right. Now, you know, we have read the diagnostic criteria for neurofibromatosis. And for this, we need at least, if you have an adult, 6 or more cafe au lait spots. So like if you notice that there are multiple small spots, so there are more than 6, meets 1 criteria. And there are more than 2 neurofibromas, 1, 2, 3, 4. So this fulfills the criteria, 2 or more. So already we have 2 criteria met, right? What else you're going to look for? That's the thing. What else? What other signs you're going to look for? Would you look at the axilla of this patient?
Yes.
Are you going to look at any hair fall, hair distribution? What are you going to look for?
In the axilla, there will be axillary freckles.
Okay, so let's see if she has. So this is our axilla. And you see there are multiple spots. and a bigger one as well. So these are what? Freckling, axillary freckling, right? These are also
Yes.
a criteria that helps you to confirm the patient has neurofibromatosis. So patient will simply come to you with rash, and also you have to check the eyes for lesion nodules. Okay. So she is wearing clothes, so you cannot see anything on her body, but what you can see is on the periphery over her face. And she told you that she had some laser therapy done, okay, to remove few of the things she had. Okay. Now tell me, if she has high blood pressure, in the exam, this has come million times in basis. Okay. So there is a more than 50% chance that many of you are going to turn up with such a case. And this is very common. So if she has headache, what would you think?
Um, with a patient with neurofibromatosis, it could be pheochromocytoma.
Excellent. Now tell me, what if you get a patient with fear? Okay, imagine what other conditions you're going to look for. Let's say a patient has fear. What other conditions you can have fear?
Okay, other neurocutaneous disorders.
Like?
Could have pheochromocytoma.
Like?
Like neurofibromatosis and VHL.
Good, very good, excellent. Now you are in the track.
Yes, VHL, it could be men.
Men, right, okay. NM and the VHL, you're very right, okay. So you're very right, okay. 1, 2, 3 NF1, men 2, and VHL chromosome 3, okay. 1, 2, 3. There are many ways you can remember them, forget it, okay. These are fun talks we do with our step 1, step 2 candidates anyway. So just going back to it, okay. This patient has a characteristic rash, but she wouldn't mention this to you. She comes to you with just headache, and from her appearance, this is spot case. From her appearance, you should be suspicious. You show it to you. These are also over her hands. That there are some lumps, bumps over her face. Okay, so it would appear to you there is a lumpy, bumpy rash. Okay, with a disease, neurofibromatosis, and the headache she had. You explore the headache, but that was episodic headache. We have different types of headache in the exam. Some primary headaches, like tension headache, band-like, cluster, unilateral, okay, which will come in clusters. Post type of headache will feel like banging, usually in males, okay, alcoholic, migraine, okay, different types of migraine comes in basis, okay, including hemiplegic migraines as well, that you have to also master. And what other headaches comes in the exam? Bad types of headaches. Sometimes headache comes with vision loss. Okay, so we should always ask, do you have any problem with the vision as well? No. Okay. And this headache that she had, this headache was characteristic what? Episodic headache. And she also had this raised blood pressure. So you should be asking this patient that is the blood pressure is always high, or sometimes you find that it goes back to normal. So the blood pressure and headache both are episodic, so they will go up and they will also come down. That's why the blood pressure at times it can mimic white coat hypertension. Okay, so that's why you need to very keen monitoring of the blood pressure, because sometimes these patients also have postural hypertension because of this fluctuation of this blood pressure. Okay, at the same time, this headache is going to come and go, episodic headache. You should ask the patient if she is sweating, excessively sweaty, if she has any racing pacing of the heart, then that would be suggestive of pheochromocytoma. So your analysis should bring out the fear, and then you should explore carrying this rash, that do you have this rash at other places? Can you show it to me? Okay, and you pick up the rashes, the characteristic rashes, the capillary spot, you pick up the axillary freckling, okay, and you also go for what else you're going to go for? The causes of this blood pressure. So tell me the causes of this blood pressure. In a patient with neurofibromatosis, this is very important. If your patient has this kind of raised blood pressure, what are the things you're going to think about? RCP, that's under That's the body, Royal College of Physicians. Renal artery stenosis, coarctation of aorta, and fear. Okay, so remember RCP. All right, RCP is going to give you high blood pressure during the exam. All right. Okay, let it not be. We're going to take precautions. It's like white coat. Okay, let it be like white coat, not permanent. So anyway, so you have to keep in mind that pheochromocytoma can give you high blood pressure, that can give you headache. Besides this, you have to ask for radiofemoral delay. That's why when you ask me the blood pressure, I told you the blood pressure in each arm. They will be mentioning blood pressure in each arm. You have to ask blood pressure in each arm, whether there's any discrepancies, whether there's a loss of any discrepancy between the pulses on the right side, left side. You should ask for a radiofemoral delay. For coarctation aorta, you should listen for any renal breathe. Okay, that will help you determine the cause of this blood pressure. So patient came to you with just simple headache, and your exploration leads to so many things, and it's very simple. And beside this, for any neurofibromatosis, what's more important in the history? Except this case, any other case, they can come in various ways in the exam. Okay, neurofibromatosis in your exam can present in various ways. They can commonly come with the headache or hypertension. They can come with hearing problem as well sometimes. Okay, especially NF2. They can have brain tumors. They can develop into this acoustic neuroma. So what you should do, first, you confirm the rash is neurofibromatosis. Rash for neurofibromatosis by looking at the rashes quickly. It doesn't take much time, maybe 30 seconds. Okay, you just check. Okay, then you have to ask a few questions for the hypertension, for the features of fear, racing of the heart, those kind of things. Also ask about any weakness anywhere, because they can have a space occupying lesion in the brain that can cause weakness, which could be subacute weakness or in acute weakness. Ask about any hearing problem. So in the head, lots of things for NF. Ask about any headache, okay, the type of headache, and whether this is all the time or episodic headache, whether this alongside any hypertension, okay, from the outside or patient has it. Ask about any hearing problem, because they can have acoustic neuroma, especially NF2. Ask about family history. If you don't ask about the family history, they will not give you full marks in communication. Yes, visual disturbance is very important. Yes, you should also ask them about family history, because they will have a positive family history. Okay, all right. Okay, and also you should be checking their back, because they can have some musculoskeletal problems as well. They can have scoliosis. Okay, and beside this, they can have some problems in the lungs. You should ask them about any shortness of breath. From the heart, you should ask them about high blood pressure. You should ask them about any like radiofemoral delay for coarctation of aorta, any complications of this hypertension like heart failure, anything that sort. Okay, so that should be kept in mind. All right. So the examination sequence is very simple. You first discover the neurofibromatosis by checking the appropriate sites. Now, if you're considering fear, you can check the abdomen. In the abdomen, what you can do, you just palpate simply. You will find nothing, but you have to auscultate to rule out the renal breed. And also you have to ask for the radiofemoral delay for the hypertension. Ask for the fundus, look for any retinal changes. Before that, check the eyes for lesion nodule. Okay, and for any such condition, check the power. Just do a handshake with her. Ask her to hold your 2 fingers with both their hands and pull it towards her. Okay, and see the power, that she has good power in the hands. Okay, done. All right, then you tell her that you have a condition that runs in families, okay, where you have these non-cancerous tumors or non-cancerous growth, okay, and this affects your nerves and various parts of your body. Fundus was normal. The fundus was normal. Okay. All right. Why we ask about the eye? Because there can be optic glioma at times. Okay. In such cases, you can have problem with the vision. In such cases, you have to ask her not to drive. If no problem with the vision, no need to ask her to stop driving. All right. Okay. So address it with her. Tell her what she has. Tell her that she has a benign tumor developing in the nerves and many other parts or organs of her body. Okay, and that's also causing these skin bumps. Okay, we call it the neurofibromatosis, and this is something that's not curable, but it has some important associations. Like she could be having also a growth over the kidneys, in one of the glands over the kidneys. Okay, it can be non-cancer or cancerous. Just say a benign tumor or a benign growth. Okay, which is secreting an excess amount of protein called hormone, the epinephrine, and that's causing the headache, the racing pacing of the heart. Okay, so what we need to do now, we need to assess her urgently with some urine test, water test. Okay, we'll also do some tummy scan, don't say abdomen, tummy scan, and we'll also refer her to the skin doctor to confirm our diagnosis. Already it's a clinical diagnosis, but in addition, you have to offer her, she has a kid, you have to refer her to a genetic counselor, because this is something that runs in the family. Okay, so she should be referred to a genetic counselor as well. To the examiner, you can say this patient on inspection has multiple neurofibroma. Some has been cured by laser over her face, and there are many neurofibromas over her body. There were a number of capsular spots, okay, over her bodies, or you can say hyperpigmented spots, most like capsular spots, and there was axillary freckling, okay, in the axilla, okay, and in the eyes, if you notice the lesion node is mentioned, or else no, okay. So these are characteristic of a condition called neurofibromatosis, and with the episodic headache and flushing and racing pace of the heart, she could be having a pheochromocytoma. So what we're going to do now, we're going to do the water test. Okay, we're going to do some tests, and that would include urinary catecholamines, okay, metanephrines, we're going to check. We'll do the abdominal imaging, okay, and we'll also what we're going to do, what more, like patient had what more symptoms. If the patient has this hypertension, okay, you can do an echo of the heart just to see if there are any changes in the heart. You can do an ECG, okay, those things you can do. And always important to check the, ask the families to rule out men too. Ask about any family history of any kidney cancer, or anyone with the family in the kidney problem to rule out VHM if you have fear in the exam, okay. And refer her to a genetic counselor. For the skin rash, if it's bothering her, refer her to a dermatologist. And educate her that not to engage into strenuous activities for the time being, okay. And for the time being, we'll manage her blood pressure, we'll involve the endocrine surgeons, okay, because she would need a surgery for the removing the fear. But before that, we have to control her blood pressure, which will take some time. We'll start her with an alpha blocker followed by beta blocker. Then we need to go for a surgery. In some other cases, they will ask you details about how you manage the hypertension in fear learning. In this case, they won't have that much time because they have got only 2 minutes. All right, so that's it from for this case. Are we good, Dr. Fun?
Yeah.
So just tell me two things. What are the causes for this high blood pressure if you find a patient with the neurofibromatosis?
Pheochromocytoma.
No,
coarctation.
I just mention RCP. That's another vibe, right? Mention the RCP.
Okay, RCP.
Yes. What's the R stands for? Renal artery stenosis.
Oh, okay. Okay, you want me to say the acronym RC? Okay.
Right,
R,
right.
renal artery stenosis, C, coarctation of the aorta, and P, pheochromocytoma.
Okay. And remember, in PACES, coarctation of aorta is $1 million baby. Okay. If you miss this baby, you're going to miss your exam, because it's very common. Though, I mean, there are many UK candidates here. Even you will not recognize it. You will understand it once you're done with the exam. Okay. They're going to bring this case, coarctation of aorta. It's very common. It comes as a dummy case, and there's a high chance this might come in any diets, in the diet 3 as well. Okay, so you should be always careful that you don't forget the radiofrequency delay in any patient who has high blood pressure. Make it a habit asking and exploring this high blood pressure. On some other day, in previous session, we gave you the red cap. We cannot give it to you today because of the time constraints. Okay, some other day we're going to give you again the red cap. Okay, we're going to give it as a gift. All right. So Dr. Fung, are you happy?
Yes, I am.
All right. So we close the case. And yes, many good feedbacks from Dr. Huggy, Dr. A, I don't know who it is, Dr. Dia. Okay. Yes. High arch palate. Yes. You should look for inside the mouth. Is high arch palate very common in patients with neurofibromatosis? Just checking. Let me remember. I mean, there could be. Okay. I know. I'm not sure. Just have to look.
I don't think so. I haven't heard that before.
No, I mean, but still I will look into it. I'm not sure about that. Sorry. I'm not sure about the high arch palate. Other things they mentioned. Other things we mentioned as well. Okay. All right. So we wanted to do